challenges that it needs to be addressed before deciding to implant a multifocal or a trifocal or an EDOF IOL. So the question is, do we go for a monofocal IOL or do we go with a multifocal IOL? So this is the umbrella where we are going to decide to discuss today. Before we go to the first clinical part, we thought that during the presentation, some of our speakers will mention the Triumph, Fine Vision Triumph IOL. So we thought it would be a good idea to give a very short introduction about the Fine Vision Triumph IOL. So allow me please to introduce Sebastian. Sebastian is the Senior Marketing and Training Manager for IOL in BVI Physio. So I give the microphone to Sebastian. Thank you.
Thank you, Mohammed. So as you can see, one size does not fit all. Remember long time ago when we have all learned it when Cinderella tried successfully a glass shoe. At BVI, we have built a fully trifocal family to get the surgeons the right lens for the right patients linked to the right expectation. So solutions are here. From the first trifocal Fine Vision Micro F we launched in 2010. This year we are already celebrating the 10 years birthday. And from the POD-F, Fine Vision POD-F to the Fine Vision POD-FT, both supported by a unique platform called WCO platform to reach a perfect rotational stability mandatory for toric version. The Fine Vision HP created in 2018 matched the WCO platform with our hydrophobic glistening-free raw material. Last but not least, the Fine Vision Triumph, which provide higher intermediate vision energy, correcting the longitudinal chromatic aberration to achieve higher quality of vision. Here is the difference between, here's the difference. We know nowadays, lifestyle is changing. People vision request is, it has to be adapting to the new technologies. And so we have to refine our vision by using more intermediate vision than near vision. Here's the difference between the Fine Vision Triumph and the Fine Vision family on the left side. So you can see both lenses gives the same addition power. So for the near vision 3.5 diopters, intermediate vision 1.75. So we have the same addition power for all the Fine Vision family. But the big difference is a distinctive energy repartition between Triumph and Fine Vision, means that we have a smooth transition of from the far, intermediate, and near vision in the energy repartition. So we are calling it a monotonic energy repartition that offers an elongated depth of focus for the patient, and that creates more depth of focus in the daily life vision. We know that we are living in a polychromatic environment. So light is colors. So these colors have different wavelengths that could create a longitudinal chromatic aberration when it passes through an optic. And there is LCA when the lens cannot focus different colors in the same focal plane. So this aberration, of course, has a negative impact on the contrast sensitivity of the patient and can, for sure, degrade the quality of the retinal image. Here is a short video to show you how we succeed to correct this chromatic aberration to the Triumph lens. So we know that the refraction, only the refraction, if you have a monofocal lens, could create chromatic aberration. So we have more energy for the blue than for the red. This difference of energy repartition is creating this chromatic aberration. We can create we can have a negative chromatic aberration due to the pattern. So we are playing with the pattern, diffractive pattern of the diffraction. And you see that the diffraction gives more red than the blue energy. So both together, we have a positive chromatic aberration due to the refraction and a negative chromatic aberration due to the diffraction, sorry. And both together, we are going to fit it together to create and to make a neutral chromatic aberration given to the optic lens. Thank you. If you want to have maybe more information, you can go directly to the website finevisiontriumph.com. So all the technical features and benefits are explained there on this website. I hope I was short and I let the time for the doctors. Thank you very much.
Thank you, Sebastian. Thank you very much. So let me give now the microphone to Professor Ahmed Assaf, whom you all know. Dr. Ahmed Assaf, being a professor of ophthalmology in Faculty of Medicine, Ain Shams University, and a fellow of the Royal College of Surgeons in Edinburgh, and he is a consultant and shareholder in Al Watani Hospital. Professor Assaf, he is going to moderate the rest of this webinar, and we will take all the questions at the end of the webinar. Thank you, Professor Assaf.
Thank you very much. Thank you, Zatar. Thank you, Sebastian. Thank you, Marine, for this invitation to moderate this webinar. My name is Ahmed Assaf. I'm truly privileged to moderate this session about a very exciting topic, which is premium IOLs after laser vision correction. I'm truly honored to have an esteemed international and regional faculty who have a very large experience and tremendous experience in the field of refractive surgery and premium IOLs. We have Professor Dr. Ahmed Elmassry, Professor of Ophthalmology in Alexandria University and former head professor of Department of Ophthalmology. And we have my friend, Professor Dr. Abdallah Hassouna, Professor of Ophthalmology at Ain Shams University. We have Rafael Bilbao, consultant and clinical behavior in Madrid, who we enjoyed his presentation last year about fine vision in Egypt, and we missed him. Maybe we can meet him again physically in Cairo, maybe the year after, maybe 2021. We enjoyed your presentation very much, by the way. And myself will talk about the last session. We'll talk about whether we can implant premium lenses in laser vision correction eyes or not. So let's start with the talk of Professor Ahmed Elmassry. Professor Dr. Ahmed Elmassry will talk about the trifocal IOLs, the beginning and the progress. Professor Dr. Ahmed, it's all yours right now.
Thank you so much, Dr. Assaf, for the introduction, and thank you, Zata, for the invitation, and thank you, Sebastian, for the introduction for the Triumph. And really, I enjoy being with all of you, with all the faculty members, and I hope that it will be of benefit to talk about the trifocals, the beginning and the progress. So I asked to start with this presentation because I'm trying just to summarize not only the post-refractive surgery cataracts, but what can we do with the trifocals, how can we manage astigmatism, the toric trifocals, and the beginning and the progress. So yes, as you all know, the aim of the trifocal is to get rid of the presbyopia or the loss of the near vision. So it's the aim of everyone just to see the distance and the near and the intermediate. And my first multifocal IOL that I inserted was on January 2006 with the old versions of the bifocals of the other companies. And when I was representing in the Emirates Ophthalmological Society in 2013, an overview of the multifocal, trifocal, and accommodating IOLs, I had a statement on the trifocals and said that, as Sebastian said, in 2010, the first trifocal diffractive IOL by Fine Vision Physiol in Belgium had been launched, and this is 25% hydrophilic acrylic, has two foci of +3.5 and 1.75 diopters. And then also, it had been said at that time that the Physiol Fine Vision, which is a new diffractive trifocal intraocular lens at that time, provides 3 useful focal points by combining 2 superimposed diffractive profiles, as Sebastian showed us, one with the plus 1.75 addition for the intermediate, and one with the plus 3.5 diopter in addition for the near vision. And this was in 2011 in the ESRS. So the first trifocal that had been inserted in Egypt was in the February 2017, and I had the honor that I inserted it for the patient, and the results were really marvelous and encouraging. Then a few months later, I inserted the trifocal IOL for one of my friends, dear friends, and it was so easy and simple, nothing new. It's the same like any other trifocal, and like any other toric, just the good demarcation and the good marks are very important, and then the positioning, and with this haptics, the stabilization was perfect. The patient is doing fine up till now, and the marks of the toric lenses, as you see here, is well seen. Just a point to remind you that your incision is very important to improve even some of the astigmatism that may develop after the trifocals, or even to correct the pre-existing astigmatism. Simply the clear corneal incision and the opposite clear corneal incision. In spite of being a very simple maneuver, I'm still all of the time send the message for the audience that you should use it, because it's a simple tool, very easy, doesn't take any time. I know a lot of my friends are using this, and simply this nomogram shows that if you do 3 millimeter incision of the keratome, 1 millimeter in front of the limbus, you can correct 1.86 diopter of astigmatism. So you're doing on the steep meridian, clear corneal incision, and opposite clear corneal incision 180 degrees just in front of it, just 1 millimeter from the limbus, it can correct up to 1.8 diopter of astigmatism. And if you can make this incision the same, but 2 millimeter from the limbus, this will improve also the astigmatism more and more, up to 2 diopters. And if you enlarge a little bit the incision with the same distances, it will improve the astigmatism and can reach up to 2.5 diopters of correction. There is no debate that the toric IOLs are definitely of better results and more predictable results, that to be honest, up to 1.25 diopter of astigmatism, I'm still using the clear corneal and the opposite clear corneal incision as a simple tool. As you saw in the previous picture, this patient was putting the one of the old multifocals on 2007, and he developed 1.33 astigmatism. He was a doctor, he was an ENT doctor, and he was annoyed with this astigmatism. Just simple clear corneal incision, opposite clear corneal incision at axis 170, improved the astigmatism and dropped up to 0.75. And this another point to stress on is that up to 0.5 and 0.75 of astigmatism could be tolerated with the fine vision IOL. So this simple nomogram helps in eliminating a lot of problems due to the post-operative astigmatism that may develop after the trifocals. Then another point to discuss is the exchange of the monofocal IOL with the trifocal fine vision IOL. I know it may be a little bit strange to hear about that patient that adapted with the monofocal IOL and he wants to change it to a trifocal one. He was a 70-year-old male patient and had his all preoperative normal data and normal preoperative investigations. And after counseling, and the counseling is the most important thing in the in this subject. Counseling is very important to point to discuss with the patient all the benefits and the disadvantages of the monofocal and the trifocal IOLs. And after the counseling, he chose to put the monofocal IOL, and the surgery was straightforward with good post-operative results. And then after a few months later, he came and he said, I'm not happy with these monofocals because I'm reading and talking to people at the same time. So I need to change these lenses with the trifocal fine vision or the trifocal IOLs. Again, another counseling was so deep to say that you'll face the halos, the glare, the quality of vision may be a little bit different at the beginning from the monofocal, but he said, I do agree. And here comes the surgeon's role. What are the problems, or not the problems that, or the tips that you should take care on exchanging a monofocal IOL with a trifocal IOL. Simply the biometry. The biometry was repeated after a few months, and the right IOL was exchanged, and the left one was also exchanged after 4 days. This is the preoperative biometry of the original lenses, as you see here in the date. It's on June 2018, and the patient had no astigmatism, nearly 1 here or 1.9 here on the steep meridian. You can open this and that, and the results of the monofocal were okay. And then after that, here is the biometry after the insertion. So it should be done on the pseudophakic mode, as you see here in the date. It's on December 2018, and again, the astigmatism in the right eye was just 0.75 diopters, and in the left eye was 1. And this is very important, that you have to open on the steep meridian and to take care not to enlarge the incision on exchanging of the IOL. And then the powers were taken, and they were again calculated with the Barrett formula. And again, the advice here, when you have this sheet, not to look for the biometry, but to look to this square and to see what is the recommended power, which is the exact power that you should insert. So you know now the powers, and you know the meridian where you open on, and this is a very short video showing this exchange. This is for the left eye. As you remember, the steep axis on 35 degrees, so you should mark and take the incision on 35 degrees in order to remove the astigmatism that you are going to induce by enlarging the incision. And this is one point to take care. And the second point to take care is the IOL release from the bag. You have to be careful. He was putting thickness 1 IOL, and it was not so simple to get the IOL out of the bag after 5 months. There are some adhesions and fibrosis. You have to take care of the cornea all of the time, putting mixture of these, visco-cohesive and visco-dispersive, and these air bubbles are a clue that there is enough OVD in the bag. Then take care on cutting the lenses. We can just unfold it and get out. There are a lot of ways to get the IOL out, but here just to show you that we are trying not to enlarge the cornea wound in order not to induce more astigmatism. Then the original bag, you have to put a trifocal IOL with these haptics inside the bag. There is no way to put it in the sulcus. So you have to be sure that the bag is totally open 360 degrees, and you needed some manipulations to allow the IOL to be inside the bag and to be well centralized. Okay, here is the procedure, but what the patient will see after these maneuvers, comparing that this patient was seeing perfect without glasses. So we did eye trace with this patient, and as you see here, the date, it was a few days after the surgery, showing that the high order total aberrations for the right eye was high, and lenticular dysfunction lens index was low because of the corneal edema and the some viscoelastic that was still present after the surgery. And then after 50 days or about 2 months, the high order aberrations had been dropped markedly, and the coma and the astigmatism and the spherical aberration had been improved. And this is why these lenses need some time for the satisfaction, and to tell the patient that you have to wait for the net result. Again, for the left eye, it's on the same date with the high order aberrations, and then after 2 months, there is marked improvement of the high order aberrations and the spherical aberration and the coma had been dropped after 2 months, and the dysfunctional lens index had been increased. So another point, when you do the cataract ready for the trifocal, and then while you are just polishing, and then you face that you open the posterior capsule. And this is the second eye of the patient. The markings are present, and the patient is ready for the second eye for the trifocal. So are you going here to put the trifocal, or you change your plan and to put a monofocal IOL? The very primitive and basic steps: don't get the irrigation out, keep the irrigation inside the eye to keep the vitreous back, and insert and give enough viscoelastic, whether what's available, whether visco-cohesive or visco-dispersive, just to fill in the globe. As you see here, the irrigation is running and the visco is inserted. And as you can see here, here is the rent. Now the decision whether to put or not to put the trifocal. Now to go back, it's just simply the vitreous is in place and just open the posterior capsule. Of course, the tension and the stress of the surgeon at that time, let me inject the IOL in the bag, taking care very slowly not to enlarge the rent, and to be sure that the haptics inside the bag. But if I'm gonna repeat it now, I would do posterior capsular rhexis and to put some visco in behind the posterior rhexis, and again to insert the IOL in the bag. So my advice here, when you have the rent in the posterior capsule, preferable to convert it into posterior capsular rhexis, and then you can put your IOL safely in the bag. The last point that I'm going to speak about is the trifocal post-refractive surgery. My first trifocal that was done for a patient that he did LASIK was on November 2017. He was a chemist, relatively easygoing personality, and this is a very important point that I think one of the colleagues is going to talk about, is the selection of patients and the personality and the type of patient that can put the trifocals or the Triumph IOLs. And he was, yes, a chemist, he understands everything, relatively easygoing personality. I did him the LASIK since about on 2006. And here is right, this is the preoperative refraction. He was mainly a combined astigmatism before the surgery, and at that time he was 52 year old. And I did for him FCAT platform LASIK, trying to use the Q value to eliminate the astigmatism and to give him some presbyopia, but he needed glasses 1 or 2 years after. It was in September 2005 on the Allegretto machine. I had no financial interest. And then the patient at that time was with visual acuity 1 in each eye. And yes, he was complaining of halos around light and usual complaints after the LASIK. And then in 2017, he was presented with cataract and unaccepting wearing glasses by any means. So I discussed with him the trifocal fine vision, and I inserted for him this lenses on November 2017 for both the left eye and then followed by the right eye. I explained again the patient's counseling. I explained everything for the patient, all the expected signs or symptoms of unhappy patient, like the glare and halos, were clearly explained. As you see here in the date, the biometry was taken on the mid of October 2017, and there was a discussion for 1 month for that patient to understand everything, to clarify for him that the trifocals may have the same halos and glare. And he said, I have the halos before, and I'm ready to have the halos again for a time and accept not to wear glasses, and it's a compromised matter. Biometry for both eyes was 20.5 diopters, and the patient was satisfied in spite of the initial glare and halos that he had after the surgery. So again, counseling the patients is very important to get the good results. And my last case is a post-myopic LASIK trifocal. She is a 70-year-old doctor that was -5 diopters before the LASIK and in each eye. And she did LASIK in 2012 and developed cataract seeking freedom from glasses. Triumph Fine Vision IOL was inserted on June 2020. What I'm gonna just to stress is not to look at the biometry and what's the power here, but you have to look to these two rectangles and be sure that the axial length is the same, the K readings, and the recommended IOLs are very important to put exactly what the Barrett gives you, because it's the most trustable formula for with the trifocals up till now. And with these powers, the patients are much satisfied. Lastly, in conclusion, I have to say that trifocal fine vision proved itself as a tool for freedom of glasses, and the post-refractive cataract trifocal needs some point like very accurate calculation of biometry, and the preoperative counseling is a must with all patients from the doctor himself, not the staff member or administration. And all data pave the way for better results. You have to have the old data for the patients because it makes it easier to have better results, as a surgeon should insist on 10% may need glasses for driving. Thank you so much. Thank you.
Thank you very much, Professor Dr. Ahmed, for this very expansive presentation. We will leave the questions by the end of the presentations to save time. So we will shift the gear now to Professor Dr. Abdallah Hassouna, who will talk about another shot at refractive. Dr. Abdallah Hassouna.
Good evening, everybody. My name is Abdallah Hassouna. I'm from Cairo, Egypt. I'd like to thank Physiol for inviting me to this prestigious webinar. I'd like to thank Dr. Ahmed Assaf for moderating. for moderating this webinar. Okay, so I will discuss in this presentation the trifocal post-LASIK correction or corneal laser correction. And we know all that millions of people have undergone LASIK surgery in the past 2 decades. And aging is a process that we will go on, everybody will go into it. And with aging, we will have presbyopia and cataract. And many of these patients wish to remain spectacle independent after cataract surgery because they lived for 10 or 20 years without any glasses. So what are the options that we have to give them? Either we give them a monovision, but monovision can compromise distance vision and it shows some difficulty in reading fine print without glasses. Or we can give them or offer them presbyopic correcting lens. But this is a challenging situation. Why? Because those patients are familiar with refractive procedure and have higher expectation, and they have had a good vision all over the years they had LASIK. And we have another challenging situation, which is the IOL and corneal power calculation due to alteration of the corneal curvature. So to achieve best results from multifocal implantation after laser vision correction, we have to have a proper preoperative plan. We have to have some consideration intraoperatively, and we have to consider some postoperative pearls. So all cataract or refractive lens exchange patient for presbyopia has to have a personal profile selection, an ocular workup, and we have to properly choose the IOL. So we have to give our patient an adequate chair time, as Dr. Elmassry said. We have to assess the personality type, determine the visual needs, and discuss the post-surgery expectation and possible nighttime disturbances. We have to choose easygoing personality and avoid heavy dependent patients on night vision like taxi drivers and patients that have high expectation. Our ocular workup in those patients is a proper history taken and a pre-LASIK, having a pre-LASIK refraction if available, a corneal topography, an accurate biometry, ocular surface assessment, an OCT anterior segment if present, and OCT macula. We will, the corneal topography and biometry and ocular surface assessment are the most important for us. So what about corneal topography? What do we need to know from corneal topography? First, we have to know if there is an ectasia or not. After surgery, after the LASIK, if we have ectasia or not. So we know ectasia from the refraction progression, the visual complaints, and a suspicious topography. We have to take notice from the maximum ablation versus steeping location. As we can see here on the lower quadrant, that this patient has a true ectasia. The second question that we have to answer is, was it a myopic or hyperopic ablation? This is determined by the Q value, which is shown on the topography map that we have. The holiday estimation shown here in the small red quadrant. It shows us if it was the previous refraction, it was a myope or hyperope, and the relative thickness that shows too on the topography map. And this can give us a clue about the type of ablation that this patient had. Why do we need this? Because some of the formula that we use, like the ASCRS calculator and Higgs-L, will ask you if this was a prior hyperopic LASIK or a prior myopic LASIK. The third question that the topography will answer is the IOL choice based on spherical aberration. Because we know that the myopic laser will induce a positive spherical aberration, and that we have to choose an aspheric lens which give us a negative spherical aberration like the fine vision, and that in hyperopic laser it will induce a negative spherical aberration, and that it is a little bit tricky to implant a trifocal or a premium IOL in such patients. And the type of spherical aberration is shown on the topography map too that we have. The The first question that the topography will answer is, will the biometry be accurate or not? On the equivalent K reading chart, the holiday report, we can see, or we can know that if this cornea is homogeneous or it has a multifocal cornea. As you can see in the small quadrant, that the graph show when the base of the curve is small, it shows that this a more or less homogeneous cornea. When the base, as in the lower case, the base is wide like this, we are sure that this is a multifocal pupillary cornea, and that it is wise to be away from those patients. What are the prerequisites of the multifocal intraocular lens patient eligible in our hospital? In our hospital, we will not do a multifocal or trifocal if there is a residual astigmatism equal or less than 0.75 diopter. As regard high order aberration, the index of surface variance has to be less than 37. The equivalent K reading zonal SD on the 4.5 millimeter zone has to be less than 0.5, and the angle kappa, which is important, has to be less or equal to 0.5. The second issue is with the IOL calculation and post-LASIK formula. There is some keratometric error post-laser vision correction. Why? Because of 3 points. The first point is that the effective lens position estimates becomes too low, and this will lead to an underestimation of the required IOL, leading to a hyperopic shift. The second thing is that the altered anterior surface and unchanged posterior surface, the relation here is disturbed. It will lead to a central corneal power that is overestimated in myopic LASIK that will give us a hyperopic shift. And the third thing, that the Ks are measured, as we know, at 3.2 millimeter, representing the same K. And the relation between the peripheral cornea and the central cornea is disturbed too. And as we know all that, this will alter the measurement and the Ks that we will use during our calculation. So how to minimize the error in our calculation for the IOL post-LASIK vision correction? We have to use a formula that is not depending on optical biometry, but it's better to be a direct measurement of total cornea using the Scheimpflug or the OCT. And we will, this is true in the Barrett True K, with or without history, and the Haigis L and the ASCRS formula that we are using. What is the Barrett True K formula? This formula is based on the Barrett Universal 2 formula, and Abu Afia, as you can see in this paper, has shown that the Barrett True K formula was better or equal to the ASCRS formula in calculating the intraocular lens power post-LASIK. And if the Barrett True K formula offered to the Barrett True K no history, when you don't have the previous history of the patient, you don't know what it was, a myope or hyperope, and it has an internal regression formula that it used to calculate the mean K, and this is available in the Varian Lens Star and IOL Master 700. And it is said nowadays that it is better, even if you have a history, to use a Barrett K no history formula. The Haigis L formula is the built-in formula in the IOL Master, and we have the Haigis traditional formula that does not use K to estimate the effective lens position. It uses the anterior chamber depth, the axial lens, and the keratometry and 3 lens constant to predict the IOL power. In the Haigis L, that is the one used in the post-LASIK, the formula is corrected based on a regression-derived algorithm. And after this, the IOL master, we will put the corrected measurement that we took from the Haigis L, and then we calculate our intraocular lens power. The holiday report is not a formula, but it is a report that we can have. It is some data that we can have. It shows us, as we said before, the amount of multifocality of the cornea. As we can see, the blue graph, when the base is a small base, it means that the cornea is a good cornea to implant or to use this eye to implant a trifocal. If it is a wide base, so you have to get away from this patient. And the other red quadrant are the data that we take and we feed the formulas that you use. And for both hyperopic and myopic patient, the 4.5 millimeter equivalent K reading zone is widely used. The last formula is the ASCRS post-refractive calculator, and this contains multiple intraocular formula, IOL formula, and it gives a constant and reliable outcome, and it's the preferred method among most surgeons today. And you can see that it gives us a minimum and a maximum and the average intraocular lens power, and it has used 4 formulas, and this is a reliable formula together with the Barrett or True K Barrett. The second or the next thing that we have to search for or to look for is the dry eye. So the ocular surface disease is highly prevalent in the cataract population. 80% of the patients presenting for cataract surgery had an abnormal ocular surface, and undiagnosed or undertreated OSDs will affect our topography, will affect our IOL calculation, the toric axis and power estimates. And post-operative, if the patient has dry eye, he will have a poor vision quality, have a fluctuating vision, ocular discomfort in spite of a good surgical result. So we have to diagnose this OSD, the dryness, and the TFOS used to has give us a few data. The breakup time has to be less than 10 seconds. We have have a dry eye if the breakup time is less than 10 seconds. We have a fluorescein or glycamine green staining, more than 5 spots on the cornea, more than 9 spots on the conjunctiva, a Schirmer test which is less than 10 millimeter, and a slit lamp biomicroscopy of the meibomian gland can give us a clue, and the tear meniscus height, when it is less than 0.2 millimeter, it denotes dryness, it denotes OSD, and we have to thoroughly and aggressively treat those patients before any surgery, and the management will be by artificial tears and gels, lid hygiene and warm press, compresses, combination of topical and systemic medication of doxycycline, weak topical steroids to treat the inflammatory limb of the disease. Cyclosporin 0.05% is a good option, and you can see here that Donenfeld has his paper, and he proved that the cyclosporin improved the visual outcome after multifocal intraocular lens implantation. Omega-3 and vitamin supplements has shown not to be that effective in those patients. If we fail, you can resort to a punctal occlusion that can help you solving this problem. The next step is the intraocular lens choice. The intraocular lens choice is a balancing act depending on corneal topography, the patient needs, and expectation. In our armamentarium, we have the extended depth of focus lens, which are good for far, good for intermediate, less for near, but they are forgiving in patients that has undergone a previous LASIK, as shown in the literature, and they have a lesser amount of dysphotopsia. And we have the trifocal, which is a great lens for good in all distances, for distance, for far, and for intermediate. And we have nowadays the new design intraocular lens, the EDOF trifocal optic, which is called the fine vision called the Triumph intraocular lens. What is the fine vision Triumph intraocular lens? It is an intraocular lens with an elongated depth of focus, and it can correct, most importantly, the longitudinal chromatic aberration. It offers a higher quality of vision at all distances with limited photic and dysphotopsia phenomena. As we can see, it is a non-apodized, so it is good in all pupil diameter, and that the steps height is 2.5 folds higher than the fine vision or the normal trifocal fine vision, and this can correct the chromatic aberration. How those lenses correct the chromatic aberration? Again, as you heard before, we have the refractive part for far of the lens. We have the power of the blue is more than the green and red, and in the diffractive area of the lens, we have the power of the red is more than the power of the green and the power of the blue. And if we put the two refractive and diffractive parts together, as in this Triumph lens, you can balance the defects and you can correct mostly the longitudinal part of the chromatic aberration. And this will improve the visual quality and contrast sensitivity. Again, the chromatic aberration, we have a longitudinal part and a torsional part. The longitudinal part will give the chromatic aberration, will give a waxy vision. The torsional part will give some rings, colored rings around the picture that you see. The impact on vision is much stronger than that of the high order aberration. So if you correct the chromatic aberration, you can overcome the effect of the high order aberration. And this is the beauty of this lens, that when it corrects the longitudinal chromatic aberration, it will correct the problems of the high order aberration in a patient previously, which he had a vision correction on the cornea, and he has a spherical aberration and high order aberration. So correcting the longitudinal part will help a lot, and you can see that there is alignment on the graph, alignment of the three colors in the far and intermediate, and to a lesser extent in the near vision. It is, as you saw before, a monotonic energy distribution. For far intermediate, there is a smooth shift of the energy between the far and the near, and we don't have this gap in the intermediate vision shown in the blue graph. If you compare it to the symphony, it has a more balanced energy repartition, and you can see the yellow arrow show that it is better in near vision. And the beauty of this lens too, there is a 91% effective light transmission 2.5, which is a good amount of light transmission. Again, the Triumph will have what we call the edge plus technology. It is a concave edge technology on the lens back surface, and it corrects the negative dysphotopsia, which is, as we all know, is some kind of problem. You can implant a lens, you can have a beauty 20/20 vision, but the patient will always complain of a negative dysphotopsia. This edge plus technology with the concave edge can help you to minimize this negative dysphotopsia. It has the usual double C loop and G-free hydrophobic material, and this material has a long-term safety and higher stability and low intraocular lens rotation whenever the Toric Triumph will be on the market. I don't know if it is on the market or not. So again, the Edge Plus technology will give us will correct the negative dysphotopsia. The correction of the longitudinal chromatic aberration will diminish the photic phenomena, and that the POT platform will give stability of the lens. The G-free hydrophobic material will cause lower PCO rate, and the trifocal technology will give good vision in all distances and with higher patient safety and satisfaction. Very fast, I will speak about the intraoperative consideration. First, the capsulorhexis, you have to properly size it. It is have to be 0.5 millimeter more than the optic. So usually it is 5.5 millimeter because the optic of the fine vision, the one I use, is 6. And it is has to be well centered, and maybe the flex here can have a role. it is the centration of the intraocular lens is critical for good function and less photic phenomena. You can use the digital marking. This technology is available, and it helps you for centration of the intraocular lens. And the centration too depends on the angle kappa. So again, the angle kappa should not exceed the 0.5 of a value. If the viscoelastic, you use a cohesive viscoelastic for proper good removal. And if you have an intraoperative aberrometry, it will help you. Last thing is the post-operative pearls. We have to listen to the patient, address his concern after the operation. We have to treat dysfunctional teeth syndrome aggressively and early. The patient is always after the operation complaining. It is usually a dry eye, so take care. And you have to identify other causes for patient dissatisfaction, such as PCO and residual astigmatism. So further intervention may be needed. And to sum it up, people who experience a successful refractive surgery consider giving it another shot, and they expect success. Multifocal intraocular lens post-LVC can be challenging, but good planning and modern technology make expectation possible. And I thank you very much. And I was long a little bit.
Thank you very much, Professor Dr. Abdallah Hassouna. You covered all the topics concerned with the premium IOLs and laser vision correction. Now we'll shift to Professor Dr. Rafael Bilbao from Madrid, Spain. He will introduce the new refractive concept of the EDOF lenses. I'm very excited about these lenses. So the topic of Professor Rafael is Isopure lens, initial experience and first clinical outcomes of the new EDOF IOL. Rafael, it's all yours.
Dr. Bilbao, you are on mute. Don't forget to unmute before starting.
Your microphone is still in mute, Rafael.
Okay.
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 Yes, perfect. Thank you.
Sorry about that. I was just thanking Professor Assaf for his kind presentation. It was a pleasure for me meeting you in Cairo last year, and hopefully we'll be able to meet all of you soon personally. And thank you also to my colleagues who are sharing with me this very nice meeting, and to BVI Physiol, to Mohammed, to Sebastian, and to Marine for their kind invitation. We're going to change the topic, and I'm going to present you the initial results with this new type of lens. Let's see if I can pass the slides. Okay, these are my financial disclosure. I have no financial interest in any of the products mentioned. And let me first of all acknowledge to my optometrist team. Without them, Alba Fernandez, Gloria Bosque, and especially Victor Tejerina, this work would have not been able. I'm very thankful to all of them. This lens, the Isopure, is a new innovative segment. And when last year, Physiol contacted me to start this pilot study, and they explained to me that the platform was the same than the MicroPure, with which we have had excellent results in Clínica Baviera. I was very pleased, and this is why one of the reasons why we decided to go ahead with the study. The lens is a preloaded lens, and acrylic hydrophobic lens, and with which we've had with the MicroPure excellent results regarding stability in the bag, very good refractive and vision previous results, and the material, which is acrylic hydrophobic, has demonstrated to be completely glistening free in different laboratory studies. in 2020, we could say that for presbyopia correction, trifocal diffractive lenses are nowadays the gold standard. However, they have some anatomic contraindication and some undesirable visual defects that make them sometimes unacceptable for some patients and not recommended in patients who do certain highly demanding visual activities in the night. And sometimes they can suppose a logistic economic limitation for its implementation in certain circumstances. This is one of the reasons why EDOF lenses were created or developed in the last year. The term EDOF, I would like to share with you, is a confusing and sometimes controversial term, as you know, diffractive and refractive lenses generate more than one single focus in the eye of the patient. And real EDOF lenses should manage to elongate one single focus from the distant vision towards the intermediate vision. And many so-called EDOF lenses work with completely different optical strategies. The extended focus in real EDOF lenses should obviate the overlapping of distant and near images, typical of multifocal, and thereby eliminating the halo effect this patient have. The problem is that by sometimes elongating this focus, certain loss of quality is lost in the retinal image. And this degradation in visual quality is what limits the performance of these EDOF lenses. The different strategies by which EDOF lenses can elongate the focus are these one: low addition diffractive optic lenses, small aperture EDOF lenses, refractive zonal EDOF lenses, and extended monofocal with spherical aberration modification lenses. Isopure lens belong to this last category of EDOF lenses. It plays with the modification of the spherical aberration of an monofocal lens. The spherical aberration are generated by the optical surface of the lens, and this makes that central and peripheral rays don't converge into a single focal point. And this succession of convergent points extend the focus points and provides the depth of focus. This is the map, the distribution of the power of the lens, which is distributed in both sides of the lens, that can extend the circle of least confusion. We have a much higher power in the center of the lens compared to the periphery of the lens. And this is the power of the asphericity that is customized on each diopter lens. And this means in the lenses with higher power, we have, generally speaking, a higher spherical aberration, a higher negative spherical aberration in the optic of the lens. And this has a tremendous importance. As I mentioned previously, we need to get to a balance between the modification of the spherical aberration that can extend the depth of the focus, but can decrease in a certain way the contrast sensitivity and decrease the quality of the images created. And getting into this acceptable balance is the clear and the success of this lens. Getting a sharp image with a definite better depth of focus without decreasing too much the contrast sensitivity of the image in these patients. Regarding the optical bench measurements that were performed in Belgium before our pilot study, they decided to do a study with the ISO2 corneal model that mimics much better the behavior of the lens into a system and into an optical system that is much more similar to the corneal human eye. And under these circumstances, the eye has a spherical aberration average of 0.28 when the pupil is dilated around 6.5 millimeters. As you can see here, usually hyperopic patients have in the cornea a higher positive spherical aberration, rather higher than the myopic patients. And this is why it is very important that higher power lenses have a higher induced negative spherical aberration to compensate for these differences. If you can have a look at this graphic, you have the monofocal in light blue that maintains spherical aberration in this ISO 2 model that is quite constant, even the pupil enlarges, and in the system where the isofocal lens is implanted, the negative spherical aberration increases with the dilation of the pupil. Regarding this difference, we can say that in physiological conditions between 3 millimeters, where the importance of the spherical aberration starts to work, and 4.5, there is no significant difference between the isofocal and the monofocal lens. In summary, the increase in the spherical aberration that makes the EDOF effect is increased in nearly 50% with a 3 millimeters pupil, whereas the quality of the image, the MTF, is only reduced around the 10%. So this makes a great improvement in the depth of focus without decreasing too significantly the quality of the image in the laboratory studies. If you can see in this USAF target, resolution targets, the image comparing the Isopure with the monofocal predecessor are both very good for the distance, and whereas for the monofocal, the quality of the chart is clearly decreased with the intermediate distances. This is maintained quite much with the Isopure lens. Let's enter into our initial clinical experience with this lens. We decided to perform a prospective clinical study with patients. I did surgery. There were patients who had cataract. There were no patients in which we were performing clear lens refractive exchange. These were patients with cataract who had no other ophthalmic problem, who had a cylinder, preoperative corneal cylinder below 1.5, and the refraction target was either a metropia or a minimal myopia in one of the eyes when these were implanted bilaterally. This is a very short video clip with the first implant performed worldwide in July 2019. Seb was in Madrid with us doing the surgery. This was an old lady with a quite dense cataract. It's a very short video clip. The cataract went without any inconvenience or problem. And what I would like to show you is especially the implantation. I'm so sorry, this is not the video I was going to show you. I was going to show you a short video. I'm so sorry about that. Just let's go faster. I wanted to concentrate on the implantation of the lens. As you can see, it's a very noble lens. It goes into the bag very gently, very, very easy, and it is very well centered and has a great stability in the bag. It's very easy to manipulate inside the eye. In fact, I perform most of my cases and I do a hydro implantation. These are pictures of these initial patients, 1 month follow-up with no significant abnormality. Regarding the results, these are the patient's data, which are not particular data of a series of patients operated with cataract with an average age of 70 years. This is the average IOL power. Patients were slightly myopic preoperatively, and at the end, due to this small myopic result search with some of the implanted eyes. There was no cylinder induction, as you can see in this table here. So we were careful to manage preoperative astigmatism with incision surgery. Regarding the visual results, this is a table presenting the results in logmar and in decimal visual acuity. Regarding distance visual acuity, the mean corrected visual acuity was about 2020, with 90% of eyes getting 0.9 or better visual acuity. Regarding intermediate visual acuity at 80 centimeters, which is distance for computer, corrected distance is around 0.6, 0.7, and more or less the same, slightly inferior for an intermediate visual acuity of 66 centimeters. And regarding in this table with the monocular accumulated visual acuity, you can see that visual acuity for the distance is around 20/20, with a monocular intermediate around 20/30, and a binocular near vision of around 20/40. This is the binocular visual acuity. As I mentioned to you previously, the binocular visual acuity for patients implanted binocularly, there were 11 patients. Visual acuity is around 20/20. Intermediate visual acuity is around 2/3, and patients have a binocular near visual acuity measured at 40 centimeters of around 0.4 in decimal scale. Very good outcomes for distance visual acuity, monocular intermediate around 20/30, binocular around 0.75, and binocular near vision of around 20/40. These are the defocus curves. This in continuous line, this is the monocular defocus curves, and this is the binocular defocus curves, the average. And we have an extended defocus range that goes from the distance vision to 70 centimeters in the binocular implanted patients and 75 in the monocular patients, with a visual acuity above 0.63, log marked 0.2. Regarding contrast sensitivity, the values obtained are within the range of this age group, and these are slightly better for binocular implantations, both in mesopic and scotopic conditions. We were willing also to control the quality of the vision and the independence of spectacle for the patient, and we decided to perform this questionnaire, the NRQL National Institute Refractive Error, regarding the quality of the vision. We asked the patient for the items 17 and 38 regarding the presence of starbursts and halos. Halos were absolutely absent in 90% of the patients, and only 10% who referred some halos were absolutely minimal. And the same for the glare. 90% of patients were stating they had no glare at all, and if some, all of them were only minimal. And regarding the spectacle independence, we follow the PRISC questionnaire published in 2017 in American Journal. And as you can see here, bilateral implanted patient, 90% do not need glasses for the distance or intermediate vision, and half of them were able to function comfortably without glasses at near vision all or most of the time. This doesn't mean patients don't need glasses for continuous near vision, but they were able to follow a certain normal life without the need to have near glasses continuously. In conclusion, the new Isopure lens seems to provide a very good distance vision quality combined with a visual improvement in intermediate vision, accentuating the EDOF effect without inducing fogging effects. Compared to the monofocal predecessor, we have similar distance vision, similar photopic and mesopic contrast sensitivity curves, and a clear improvement in the defocus curve and better tolerance to residual metropia. And a mini monovision strategy living in binocularly implanted patient around half a diopter improves binocular intermediate vision without modifying significantly binocular distance and near vision. There is a high level of patient satisfaction with very reasonable, quite reasonable spectacle independence obtained. And we need to extend these studies to confirm these initial promising results and positive inputs from these first patients. we need to directly compare these outcomes with the predecessor monofocal aspheric model MicroPure, which is what we're doing right now. And we need to investigate the clinical performance of this lens in relation to the physiological changes in the pupil size, in the changes in the pupil centration. We need to know if what is the real importance of lens decentration compared to the pupil, and what is the behavior of the lens depending on the lens dioptric powers used. And we would like to have also a study evaluating the lens in real scotopic conditions. In our opinion, this lens could very possibly be used in some ocular conditions that are considered right now contraindications for multifocal lens implantations in patients who want to improve their spectacle independence compared to a classical monofocal aspheric lens. And this lens could be better addressed as a monofocal lens with extended focus, because it extends the uncorrected depth of focus and improves clearly the spectacle independence of our patients. Thank you very much.
Thank you very much, Rafael. It was a very nice presentation and a very nice introduction for the new technology of EDOF lenses that are based on the spherical aberration. Now it's time for my talk. So we'll leave the questions until the end. So I will start my talk right now. So let me wrap it up to answer the question whether to implant a premium lens after laser vision correction or not. So as you know that laser vision correction or LASIK is one of the most common surgical procedure in the world. And it's estimated that more than 40 million LASIK procedures has been performed since its introduction in 1991. And as you can see in this graph, about more than 1 million procedures of LASIK were performed per year between the 2000 and 2007. So each year between 2000 and 2007, more than 1 million LASIK procedure has been performed at that era of time. So when these patients age and develop presbyopia or cataract, they will search for a new refractive procedure. And this indicates the growing demands for cataract surgery and presbyopia refractive lens exchange after previous laser vision correction. So this is the dilemma we are facing right now. So previous laser vision correction, when they are getting older, these patients, when they get cataract, they are sensitive to reduced vision compared to the senile age group, because the added lenticular higher order abrasions of the cataract on top of the induced corneal higher order abrasion after the laser vision correction will severely compromise the visual quality. The second part here is that they usually complain of cataract at early stage and age, and then these patients, because of the youngest or younger age compared to the senile patient, they are active and they have active lifestyle compared to the senile patients. So they ask for spectacle independence. They want to drive, use the computer, mobile phones without spectacles. And these patients, of course, have high expectations. They are passionate for spectacle independence. That's why they did LASIK, and they expect the same refractive results enjoyed after corneal refractive surgery. So on the other hand, we have the multifocal IOLs present here for around 1 or 2 decades, and this multifocal has been successfully implanted in clinical practice and provide good effectively for distance and near visual acuity, with some reported side effects include decreased contrast sensitivity and halos at night time. And it was mentioned that the contraindication for the multifocal IOLs implantation include glaucoma, retinal pathology, and other issues, including previous corneal laser surgery. Why? Because we have 2 main issues here in eyes with previous laser vision correction. It's difficult to estimate the corrective IOL power. So we have a biometry issue and we have an aberration issue. We have a biometry issue, which is the most important issue here in premium IOLs with previous laser vision correction eyes because it's difficult to estimate the correct power of the IOL. On the other hand, we have induced aberrations, and these corneas after laser vision correction have been turned to be multifocal corneas. And so implanting a multifocal lens under or in the presence of multifocal cornea will definitely reduce the quality of vision in these patients. So we have two major concerns here when dealing with premium lenses in eyes with previous laser vision correction. Let's start with the biometry issue. We have three main factors that cause difficult to estimate the correct IOL power. We have variation in the anterior corneal surface, and we have issues related to the difference in the curvature between the anterior and posterior corneal curvature ratio, and we have a biometry formulas issues. Let's start here with the variation in the anterior corneal surface. As you can see here, this is the graph or the cornea after myopic laser. You can see here the large variation of the anterior corneal power on the anterior corneal surface compared to the Persian cornea. And this makes the estimation, correct estimation of the corneal power in the central corneal power in the central zone quite difficult and quite unpredictable. And that's why there is inaccurate reading of the K reading by keratometer and topographer, and definitely will cause incorrect IOL power calculation. And the other issue here, because the disturbed ratio between the anterior and posterior corneal curvature, the inversion untreated cornea, this ratio is estimated to be fixed at 82.2, but after myopic laser, we have now flattening of the central cornea and vice versa after hyperopic laser, and this ratio is disturbed, and the calculated refractive index of 1.3375 is not valid anymore in eyes with post-laser vision correction. And most of the biometric formulas, most of the fourth and all the third generation biometric formulas estimate the effective lens position based on the K readings. So after myopic laser vision correction, the cornea turns to be flatter. And this caused the biometric formula to falsely assume that the effective lens position is closer to the cornea. And the opposite after laser vision correction to treat hyperopia, these biometric formula will falsely assume the effective lens position to be further away from the cornea, and this will cause under correction and over correction of the calculated IOL power, and will result in ametropia after IOL implantation. So that's why it's quite difficult to estimate the correct IOL power, and it's still questionable whether we can implant a premium lens in eyes with post-laser vision correction. Let's see this example you can see here. This is after myopic implantation. This is from the anterior corneal surface, and this is after calculation by the Scheimpflug image. We calculated here the total effective corneal power because, as you know, the Scheimpflug image can measure the posterior corneal curvature and can calculate the total effective corneal power. And you can see here the total effective corneal power, or the actual effective corneal power, is flatter compared to the anterior surface of the cornea, and this difference is 0.7 diopter. Of course, it will have its impact on the calculated power of the IOL. And of course, with the, as expected, with the larger ablation or the deeper ablation, the larger the difference between the anterior corneal power and the total effective corneal power. And you can see here, the difference jump up to 1.9 diopters. So this is one issue. The other issue is that we have many formulas now trying to solve this issue of the calculated power of the IOL. And these formulas can be accessed, as mentioned previously, through ACRS calculator and website. You can see that the website has 3 modules for eyes with prior myopic LASIK or PRK, and eyes with prior hyperopic LASIK or PRK, and eyes with prior RK, refractive keratotomy. This website provides good choice, is a good choice for surgeons who cannot choose the proper calculation method, and has been subjected to recent revisions to exclude the methods that require the history, because it has proved now that the formulas that requires the pre-LASIK data, the pre-LASIK K readings and refraction prove to be less accurate compared to the no history formula. So this website has been subjected to recent modifications to improve its accuracy in predicting the correct IOL power. Now we have the new generation formulas. One of these formulas include the Barrett-Rouquet formula, and the Barrett-Rouquet formula is based on the Barrett Universal 2 formula. It can be accessed through Asia Pacific Association of Cataract and Refractive Surgery website or the American Society of Cataract and Refractive Surgery website. It predicts the posterior corneal power to calculate the effective corneal power and hence improve the prediction of the to hit emmetropia more frequently compared to the other formula. This formula has two versions, one that requires the pre-LASIK refraction and the other version that requires no pre-LASIK refraction. Anyhow, both formulas or both versions does not require the pre-LASIK K readings. So just only the refraction if available or believed to be accurate. If this refraction is believed to be inaccurate or unavailable, we still can use this formula with no history moved. Now in the literature, it has been proved that we have improved accuracy in prediction the IOL power. In one study, you can see after myopic LASIK, 57% of the eye were within 0.5 diopters based on the ACRS calculator website, and 85% or more within +1 diopter of emmetropia. And the effective lens and the effective efficacy index and the safety index were reasonable, and there are significant correlation between the refractive outcomes and the pre-LASIK spherical equivalent. The higher the initial myopia, the more myopic refractive outcomes after implantation of premium IOL. So this should be considered, because the larger the myopic ablation, it will end with slightly or trend toward myopic refractive error after premium IOL implantation. On almost the same regards the eyes after hyperopic laser vision correction, almost the same results, but there is no correlation between the pre-LASIK refractive error or pre-LASIK spherical refractive hyperopic error and the refractive outcomes in comparison to the myopic eyes. Here you can see here in this table that the cutoff value here, maybe let's say the safety cutoff value that we can still predict effective or hit emmetropia after laser vision correction is 6 diopter of ablation after myopic laser ablation, because eyes with pre-laser spherical equivalent of 6 diopter or more, they are less predictable and tend to have more myopic outcomes compared to the eyes with less spherical equivalent of 6 diopters or less. We have modern tools now to calculate the power of the IOL intraoperatively based on the intraoperative aberrometry. However, it adds time and cost to the surgical procedure and proved to be less accurate because of sensitivity of these devices to the variation in the intraocular pressure and difficulty in estimating the effective lens position in the aphakic state intraoperatively. And these devices as well are sensitive to the corneal edema, and measurement are sensitive to the corneal incisions. So the consensus now about these devices that it has no apparent clinical benefits so far. We are now able to measure the posterior corneal surface with the Scheimpflug devices, which have been around here for 15 years, and many other formulas have been developed to extract the effective corneal power and to be included with the biometry formula for better accuracy in calculating the IOL power in eyes after laser vision correction. And we have now the ability to measure the posterior corneal surface based on the OCT, not the Scheimpflug image. We have the swept source OCT biometer, which can measure the posterior corneal radius and calculate the effective corneal power. As you can see in this example, it proved that the effective corneal power or the total K is different from the K measured on the anterior surface. This eye after previous laser, you can see here that in this close-up window, you can see that the total K here, astigmatism, is larger than the K measured on the anterior corneal surface, and actually the total K was slightly flatter compared to the measurement taken from the anterior corneal surface. We can access these data in detail from the corneal values of the swept source OCT biometer. We can measure again the back surface values of the posterior corneal astigmatism and posterior corneal radius with better accuracy compared to the shine fluke images. So we have now more and more developed formulas that not only predict the power of the posterior corneal surface, but can included the measured posterior corneal surface for better accuracy. We have the Barrett through K, the total K you can see with the measured posterior corneal astigmatism or posterior corneal surface. And it proved now that this formula provided less prediction error with compared to the ASCRS calculator with statistically significant better results compared to the other formulas like the Haig's L and average ASCRS and the Schemmass formulas. And the highest number of eyes within plus or minus 0.5 was with the Barrett through K with measured posterior corneal surface now. So we have the ability not only to predict, but rather to measure the posterior corneal surface. What about the aberration issues now? Now, the biometry has been solved mostly by the new formulas, by new devices that can measure the posterior corneal surface, and new formulas dedicated for eyes with previous laser vision correction. What about the aberration issues? Now we have modern ablation profiles with less induced higher order aberrations. As you can see, this after myopic laser aberration, you can see large optic zone, pretty well centered, and you can see here that the coma here is within the normal range and the spherical aberration slightly induced, but still acceptable range compared to the larger or the older aberration profiles. Of course, we should get away from these corneas with the premium lenses because this eye with a small ablation zone, it's quite difficult to correct or to compensate for the induced aberration of this cornea. And you can see this cornea with decentered ablation. Of course, it's quite difficult, of course, to provide a good quality of vision with premium lenses. So we can select some eyes with a good ablation profile with less induced corneal higher order aberrations, especially the coma and spherical aberration, and still we can implant those eyes with the premium lenses. And we have, again, a powerful tool now to optimize the corneal surface. Let me show you this example. This patient has been implanted. It's coming for visual rehabilitation after corneal scar. And you can see in the middle here, this is the corneal scar. This is the corneal topography. Because of the corneal scar, you can see flattening in the upper half of the cornea and steepening in the lower half of the cornea because of the ruptured globe. And this patient has been subjected to topography-guided surface laser ablation to trying to optimize and regularize this cornea. And you can see here that the central cornea now is turned to be a regular astigmatism. Of course, this patient is not good candidate for premium lenses, but this patient have been implanted with a toric lens. But let me show you, this is an example of how powerful tool now we have with the topography guided laser ablation. We can optimize the corneal surface and trying to correct some of the corneal aberrations or some of the irregular astigmatisms to make these eyes more amenable for the premium lenses, especially the EDOF lenses. So what about the lenses? Previously, the multifocal lenses has some optical and optical issues compared to the new technology of the trifocal lenses and the EDOF lenses. Those lenses are very well known of nighttime halos and visual dysphotopsias. Now we have introduced trifocal lenses with modern optics. I don't go through the specs of these trifocal lenses because it's out of the scope of this presentation. However, several studies now provided or proved the decent or good refractive outcomes after implantation of the trifocal lens. This study showed the implantation of the micro F trifocal lens with eyes with previous laser vision correction, hyperopic and myopic. They included 241 eyes. You can see here that about 50%, 46% of these eyes has uncorrected distant visual acuity of 1 and Jaeger 3 of near visual acuity, and 81% of these eyes has decent functional vision of distance of 0.8 and decent functional vision at near distance of Jaeger 4. So this proves now we have new technology of the IOLs that can be implanted in eyes with previous laser vision correction, and still we can get a decent functional visual outcomes. You can see in the other graph here that about 80% of the eyes were plus or minus 0.5 diopters of ametropia after implantation with the micro F trifocal. So this proves that the quality of the IOLs and prediction, the accuracy of the biometry now has been improved, so we can benefit of this technology in eyes with previous laser vision correction. Of course, now has been discussed, and previously we have the new EDOF lenses. We have the Triumph diffractive EDOF lens, and we have the Isopure lenses. These are new technologies. We are very exciting technology. We have now lenses that based on the spherical aberration to extend the depth of focus, and we have lenses now that target chromatic aberration to compensate for the induced visual aberration induced by the laser vision correction, so to provide a decent visual quality after implantation of these lenses. In comparison to the EDOF lenses with the trifocal, it has been proved that in this bench study, they studied the modulation transfer function of the EDOF lens and the trifocal lens with induced myopic LASIK, and you can see here with the EDOF lens, here this is with the EDOF lens, after myopic LASIK, there is no compromise in the distant visual modulation transfer function, rather than a shift toward the negative 0.5 diopter of defocus. While in the trifocal here, you can see after induced myopic LASIK, the induced spherical aberration on top of the lens to see the optical performance of this lens. You can see significant reduction in the outcomes or the optical performance of these lenses after induction of the spherical aberration. So probably the EDOF lens provide a better bright future in eyes with laser vision correction compared to the trifocal lens. Again, in the same study, you can see here that the EDOF lens has more tolerance to the ametropia compared to the trifocal lenses, and surprisingly, even after the myopic LASIK, ablation, and these lenses has better visual outcomes for distance with the minus 0.5 diopter of defocus. So it proves that the EDOF lens are more forgiving for ametropia, even in the presence of the eyes within the presence of post-myopic laser vision correction. So biometry is more critical for the trifocal lenses, and of course for EDOF lenses. However, the EDOF lenses are more forgiving for the potential post-operative ametropia in case it happened, especially if it was toward the hyperopic side. Let me show or finalize by this clinical case. This is one of my patients that she is 46 years old. She had a previous laser vision correction. She had previous LASIK 12 years ago, and this was her refraction because of the nuclear cataract here. And this is her corneal topography. You can see a slight flattening here in the central part of the cornea here. And of course, the cornea is expected to be thin. And this is after implantation of the Triumph lens. You can see here, first of all, let me show you, this is the refraction. So this is the function of the accurate biometry. This is her refraction now. It's only 0.25 of cylinder, and we hit emetropia, spherical emetropia. And let me show you here. This is the cornea here. This is the axial cornea, and this is the internal aberration. You can see the internal aberration. This is the function of the lens itself. This is the internal aberration. You can see that surprised that the total coma or the coma induced by the lens here is less than 0.1 microns, and the total trefoil induced by the lens here is 0.15, and the total spherical aberration induced by the lens, internal spherical aberration, is 0.14. So that proves that the lens does not induce significant internal aberration, and the lens is very well centered and it's not subjected to tilt because it's as a function of the internal coma proved by the internal coma values is very low, and this proves that the lens is very well centered and is not tilted. And you can see here, this is the corneal higher order aberrations, and the patient quality of vision surprisingly was very decent. This is the modulation transfer function as a function of contranstivity. You can see this contranstivity is almost like the normal contranstivity compared to the normal subjects. This eye had already previous myopic laser vision correction, now have been implanted with the EID of Triumph lens, and this is the point spread function. And you can see here, this is the simulated visual quality that the patient can see. The patient, by the way, the hair refraction was zero, there was emmetropia, and visual acuity, uncorrected distant visual acuity, was 0.9 on Dismal scale. And the patient was very pleased by the refractive outcomes, and there is no complaint about the nighttime dysphotopsis or reduced contranstivity by this patient. I have several patients like this, and these patients are satisfied and happy with the results, especially with the EID of lenses. So my final slide is to answer the question whether to implant the premium IOL after laser vision correction, yes or no. Yes, if we have a good ablation profile and good centration and large optic zone. Yes, if we have access to improved biometry formulas and devices to calculate the posterior corneal astigmatism. Yes, because we have new IOLs and new EID of lenses with improved optics. Yes, if we have enough corneal tissue for possible laser touch-up after implantation of the premium lens. And no, if the K readings is too flat, flatter than 36, or too steep beyond the 46, 47 diopters because of the induced aberrations and the prediction after IOL implant, the prediction of the biometry will be less accurate compared to the eyes within the 36 to 47 diopters. Of course, no in eyes with decentered ablation or with small optic zone. No, if the patient does not understand that he might or she might go for laser touch-up after implantation of the premium lens. Thank you very much for your attention.
Thank you, Professor Assaf, for this amazing presentation. It's really, really very, very informative. I'm sure, like everyone, everybody has learned from this presentation, from patient selection, and to follow the criteria. I will check the questions, answers, if we have any. So now we open the questions and answers. We start to receive some comments. So
until you filter the questions, let me ask Dr. Ahmed Elmassry about his presentation. Dr. Ahmed, I know that you do a lot of patients with keratoconus, and you have a lot of patients with keratoconus. Would you consider a patient with a suspicious cornea of keratoconus to be implanted with a premium lens, whatever the premium lens is?
Honestly speaking, it's a big debate, and it's a hot point whether to implant a premium IOL or trifocal IOL for patients with keratoconus or even suspicious. Honestly, these patients are very demanding, and the patients with keratoconus, definitely they have an irregular cornea, whether irregular anterior surface or posterior surface, or the posterior floats are a little bit high. So I do advise not to put trifocal IOL for patients with any kind of irregular cornea, except if the patient had been cross-linked and had been regulated with the topo-guided, as you show in your very nice case, that the patient with the scar in his left eye. So if you can have a regular cornea, patient understands that he may need another touch-up, as you said before. Yes, we can do it, but very cautiously. But the general advice is not to put premium IOL with an irregular cornea in general, and keratoconus especially.
Yes, I agree with you. Yes. Now we have the Athens protocol, or whatever, the topography guided laser ablation for the mild keratoconus, so we can regularize the cornea or optimize the cornea for some time before deciding or taking the decision to implant the premium lens or not. So maybe we can do topography guided laser ablation and then on cornea cross-linking, whatever, simultaneously or sequentially. Then we can follow up this patient. If the patient proved to have a regular cornea and stable, we still consider implantation of these premium lens. Thank you very much for this great answer. Professor Dr. Abdallah Hassouna, you highlighted the importance of chromatic aberration. Can you elaborate the importance of correction of chromatic aberrations for the sake of better visual quality, especially in eyes with the previous laser vision correction?
Yes, as we know that the impact of chromatic aberration is on vision is more than from the high order aberration, and that we know that the longitudinal chromatic aberration is more important than the torsional one, and that the torsional chromatic aberration had the same effect of the high order aberration. So if we correct the longitudinal chromatic aberration by the special design of the Triumph intraocular lens, we can overcome the high order aberration impact of a post-LASIK cornea. This is the issue. So these lenses can correct the longitudinal type of chromatic aberration, which has more impact on vision than high order aberration, and which is equal to the torsional one. So this is the good thing in those lenses.
Okay, thank you very much, Dr. Abdallah. Dr. Rafael, can you ask me, do you have any experience with the Isopure, and have you tried the micro monovision in these lenses so to provide more depth of focus for these patients?
Yes, as I mentioned in the study, patients implanted bilaterally are usually target to have in one eye around 0.5, 0.75 of myopia, and this improves the intermediate binocular vision without deteriorating the distance vision. So I think it's a good thing in order to improve the spectacle independence in the patient to leave one eye slightly myopic.
And would you consider these lenses in eye with large angle kappa?
Well, regarding angle kappa and implantation of premium IOLs, you know, there is quite a lot of controversy, although most of the literature points that implanting these lenses in eyes with more than 0.5 millimeters of angle kappa is not very recommended. Angle kappa is something that I looked at, but I'm not as worried as other issues such as corneal irregularities, good tear surface quality of the eye, and other items, or the status of the retina of the patient. So specifically with these lenses that are fairly monofocal, I don't think angle kappa should be of a very important concern, to be honest with you.
Okay, thank you very much.
Assaf, I have a question for you.
Yes,
let me read
Dr.
it.
Nancy. Yes, Dr. Nancy.
Yes,
yes please read the question, please, so I can prepare my answer, because this
sure.
seems to be a very tough one.
So Dr. Nasir Ragad from Jordan, we look forward to host you as a speaker one day soon, I think. So she's addressing the question to you, Dr. Assaf. What if, despite all what has been done to ensure premium results, taking all the notes mentioned, but yet you are faced with an unhappy patient? As you know, some patients have a mindset image of expectation despite reasonable chair time. When would you consider explantation?
Of course, the only solution for this patient is to explant this lens with the monofocal lens. The timing of explantation is very controversial. So we can think of explantation very early because of the patient complaint and the patient keep nagging I'm not happy, I'm not satisfied with the results, or we can leave some time until the patient adapts or understand what the concept beyond the multifocality or the EDOF lenses. So generally speaking, I would consider explantation of these lenses between 6 to 8 weeks. So I believe this is the sweet spot that I give the patient enough time that the patient might tolerate or adapt to the nighttime or the visual dysphotopsias, and yet it's not too late. So making the explantation challenging, especially if this lens is hydrophobic lens, because as you know that the hydrophobic acrylate stick very early to the capsule. So I believe that explantation is the only solution, and the timing between 6 to 8 weeks.
Assaf, can I add something, please?
Yes, please.
Usually those patients, most of them have severe dry eye, especially in our area in the Middle East. So we have to do whatever in our hands to treat this surface eye disease and thoroughly and aggressively. And I think most of the patients, before thinking of explanting this lens, I think you have to give them a chance to treat this dry eye, because you know that the incision of the cataract, the drops that we use, the age of the cataract, our weather, whatever. So I have lots of those patients that when I treated the dry eye thoroughly and cyclosporin and things like this, I think I could escape with an explantation. Thank you.
Would you put punctal plugs, Dr. Abdallah, for these patients?
I didn't resort to till now, but why not? If I tried everything, maybe I'll put them punctal plugs if this will help. But usually with cyclosporin and with dexocycline oral and non-preserved lubricants, most of them, not all of them, but most of them will be happy after a while. Either they will get used to the pictures or the neural adaptation, or the dry eye will be lesser and you can escape with an explantation. How many premium IOL did you explant, Assaf? I didn't.
I explanted for my patients. I didn't explant any. I didn't explant any lens, but I explanted for other colleagues because of the bad choice. Because I found that some colleagues who have irregular corneas have been implanted with the multifocal lenses or the incorrect power. So I have explanted about 8 or 10 IOLs because of the issues. I believe that it was the wrong choice for the IOL or the patient.
Yes, me too. I explanted patient for the night driving problem, and he was putting an EDOF, extended depth of focus, but he was not happy at all. And that's why selection of patient is mandatory. And again, as you said, I explanted one of our colleagues multifocal IOLs because of the wrong biometry. But usually the rate of explantation is very low because you have many other choices to cover, whether the dry eye, whether to do LASIK or touch-up for the patient's post-refractive. So explantation rate really is very low.
Dr. Rafael, I think you want to comment?
Yes, thank you very much, Ahmed. I would like to really congratulate you for your presentation. It is extremely helpful and very scientific. Just to point out, in Clínica Baviera, we have an extremely large base data patients, and we have been performing retrospective studies on patients previously operated of photorefractive corneal surgery. Let's call them LASIK patients, although many of them were treated also with PRK, in patients who had lens refractive surgery thereafter. And we have been analyzing them with the help of a colleague, Dr. Rosario Cobo. And the results we have found and the recommendations we are following now are very similar to what you concluded in your presentation. Results after laser vision correction and trifocal implantation are quite safe. The result, especially in previous myopic treatments, is quite good. In some values similar to that of patients implanted with monofocal lenses. In post-hyperopic treatments, the results are not so safe. So all this selection data that you were explaining are far much more important in previous hyperopic patients. In my experience with this patient, I would stress also the selection and what the rest of the colleagues explained is absolutely crucial. Quality surface of the eye is absolutely crucial. Having, especially in hyperopic patient, a well-centered treatment with a not too important negative aspheric aberration, that is a not too curved cornea, is very important. And as you mentioned, being able to do an enhancement afterwards is also crucial. But the results have been for us surprisingly good, especially in myopic patients. Hyperopic patients, I do trifocal implantation if the previous ablation has not been too important and that the cornea looks quite normal. But yes, our recommendations now follow what you said in your presentation. These results will be published hopefully soon in the forthcoming months.
Thank you very much. We are excited to see these paper published. And I agree with you that maybe the myopic laser ablation gives better results with the premium lenses compared to the hyperopic. But fortunately, we don't have a lot of hyperopic laser vision correction. And the amount of hyperopia usually corrected is between 2, 3, 4 diopters. And we are lucky enough, we have some sort of corneal regression. So that makes sometimes the cornea looks normal, as you mentioned. Yeah. In this case, yes, I totally agree with you. Yeah.
Yes, you have to make sure when you do this lens implantation that the cornea is stable and it's not regressing anymore. But yes, I had the data here, and most of the patients implanted had been previously operated of hyperopic LASIK more than myopic. We have trifocal implants implanted in 549 hyperopic eyes and myopic LASIK 320. So it is far more common in hyperopic patients to ask for this treatment than in myopic patients.
Yeah. Okay.
But you have to be, as you mentioned, especially careful with this hyperopic previously treated patient.
Yeah, exactly. Dr. Abdallah, do you have a comment?
Can I add a comment? Those hyperopic patients or previously hyperopic patients that have been having laser correction, if you do a monovision, because they are already hyperchlorate and they have a depth of focus, they can read. So if you do a monovision on these patients, they are happy because they already can read and they will continue reading with a small monovision that will not affect their far vision and they will add to the depth of focus that they have. So I think monovision in previous hyperopic LASIK is safer than having trifocal lens.
I completely agree. It's a very good option. And regarding the model of the lens I was presenting, the Isopure, I would not recommend to use this lens with a highly negative spherical aberrations in patients having been performed a hyperopic LASIK previously, because they already had a high negative spherical aberration. And in the same way, I wouldn't use this Isopure lens in keratoconic or suspiciously keratoconic corneas, because this patient also had very negative spherical aberration values in the cornea, and I wouldn't be very safe. These are probably the two only clear contraindication for the use of the Isopure lens. But I completely agree with you. Monofocal implants and a monovision in these previous hyperopic patients is a wonderful option and very satisfying for most of them.
Thank you.
There is one question from the audience about the angle kappa. Would you implant a multifocal lens in patients with large angle kappa between the limit 0.4, 0.5? Would you like to answer this question?
0.5 I wouldn't, because usually if you have a big angle kappa, and this is the issue in the hyperope too, because they have a high angle kappa, you are afraid that the rays will hit one of the circles, so that will add to the vision disturbance. So I will not for me. I will not implant and I showed it in the presentation, more than 0.5.
Yeah.
No, what about a patient having an early stage of dysphotopia in his endothelium?
Fuchs dystrophy, you mean?
Yes, yes, Fuchs endothelial dystrophy.
No, I don't advise to put trifocal in these cases because these patients are usually susceptible to have later on the MAC or the ZEC. So they may have another surgery with different refraction, with different posterior corneal surface. So I don't advise to put trifocal for these patients.
We often have the doubt of implanting a premium IOL, a premium multifocal IOL in patients who have maybe a few guttas in the endothelium. It depends on many factors. If the patient is young and the number of guttas is quite extensive, of course not. It's not recommended, not only for the risk of a corneal transplant in a later age, but also because this irregularity in the corneal endothelium will decrease vision quality, and adding another optical media with a complex optic such as a trifocal lens would make things much more difficult. But some patients have a guttas, isolated guttas, covering not a large percentage of the cornea. I think these patients could be good candidates for trifocal implantation if the patients are aged and have not too many extended guttas.
Okay, Zatar, I think we reached the conclusion of this session, or what?
Yes, yes. I would like to thank everyone. Thank you, Professor Assaf, for moderating this session and for your great presentation. Thank you, Professor Ahmed Elmassry and Dr. Abdallah Hassouna, Professor Abdallah and Professor Rafael for your participation as well. Great as usual. We all learned a lot and we look forward to meeting you soon. Great presentation. Enjoy your weekend. Thank you very much and looking forward to see you all.
Thank you, Mohamed.
Thank you.
Thank you, Sebastian, of course. Thank you, Sebastian.
Bye-bye.
Thank you. Thank you to all of you.
Thank you. Have a good evening.
Thank you.
Bye-bye.
Bye-bye.